I'm speaking on the CMC joint arthritis of the thumb. It is one of the commonest arthritis in the hand, degenerative arthritis in the hand, and probably one of the four commonest causes of radial sided pain in the hand. Its incidence is more common in females, and generally there is pain and difficulty in activities of daily living. Clinically, there is tenderness and grating on movements, and we are always been taught the step sign of Forestier as a clinical guidelines for the diagnosis. Plain radiographs are generally adequate, and we use dead lateral views for the staging of the disease. And generally, four stages have been described by Eaton. The first stage is generally asymptomatic. I'm sorry, they are not seen on the X-ray. Nothing is seen generally on the X-ray. The patient is having pain, and X-rays are non-significant. There is we hardly see much patients in grade 2 actually. They generally, most patients are seen in grade 3. I have yet to see a patient with grade 4 as described by Eaton, but grade 2 and grade 3 are quite interchangeable in all the cases. Sorry, not shifting.
Tap on the screen 3 times, sir.
Okay. So we see the grade 1 patients or stage 1. Generally, X-rays are unremarkable. They have pain. They always have pain on movements. They complain of pain, but X-rays are not significant. And if we tell the patients that you are developing CMC or arthritis, they say that you are probably overdiagnosing things. So in the grade 1, generally there is what is needed is activity modification. They require sprinting and rest, and they require appropriate doses of anti-inflammatory drugs. Occasionally, steroid injections can be tried. I don't use it. Does it work? It generally doesn't. Patients will, they are ladies, they generally keep on doing household work, and the symptoms will recur with use. Now, grade 2, you'll always have a slight reduction in the joint space. You will have some medial osteophytes. You will have some lateral subluxation in these cases. And here, you try the conservative methods, but generally they don't succeed. These methods have been described: the volar beak ligament reconstruction, the metacarpal osteotomies have been described. They generally don't work because generally by the time the patient comes to you for surgery, the disease has progressed. Joint resurfacing and interposition also have been described, but it doesn't work because of reactions, loosening, and instability. And generally, like the current pandemic, the incidence, the disease generally starts rapidly progresses from grade 1 to grade 3 in due course of time if patient doesn't take care. And you'll see these various radiological appearances: the lateral subluxation, sclerosis, reduction in joint space. You can see a huge medial osteophyte here. And you can see that though this has been described as grade 4, generally you don't see a scaphotrapezial arthritis. So this is basically also grade 3 only. So you see these pictures, and you'll see various appearances of every appearance of grade 3 is different. I would say you can see that this metacarpal is hinging on the lateral aspect of the trapezium. You can see that there is a new bone here. You can see the medial osteophyte here, and you can see very gross advanced disease here with features of subchondral sclerosis, lateral subluxation, loss of joint space, and medial osteophytes. The disease keeps on progressing. Nothing really helps in this. And you can see such grotesque examples of this problem. And the arthritis keeps on progressing, as I've said, with subluxation. And surprisingly, even with severe arthritis, many patients are asymptomatic and they say that there is no problem, only there's slight deformity. Occasionally they get pain when they do some severe household work or like opening a tight bottle. And even after long-standing diseases, you can see this MP joint is subluxated here. there is an adduction contraction of the thumb, there is a Z deformity here. These patients are somehow unwilling for surgery. But even with this severe disease, you can see that this scaphotrapezius joint is normal. So basically, this also is a grade 3 disease. Now, this is a very nice paper described in 2011, which has compared all these 8 methods of treatment. And they found that there is no procedure which is superior to another. So basically, going by our clinical judgment and the type of practice we are in, we have to decide what works best for our patients. For stage 3, this is the stage which generally requires treatment, and then the treatment is successful in these cases. The CMC joint arthritis is described, or arthritis is described, which I think it works well for young patients. I don't do it. Arthroplasty has been a failure, utter failure. There are so many papers, so many methods of arthroplasty. I would say interposition, implant arthroplasty. They're all failed. Every year we get a new design. The thing which works best in most people's hands and in my hands is this trapeziectomy, coupled with other procedures which I've described. The problem with arthritis is that you don't get adduction and the load is shifted to the proximal and distal joints. In arthroplasty, either hemi or total, you get instability, you get loosening, and there is always a migration. So what I do and what is described or what is done in most of the cases, most of the centers, is a trapeziectomy. But the problems with the plain trapeziectomy are it causes instability. It can cause collapse and shortening, and it can cause, occasionally it can cause scaphometacarpal arthritis. It's a very nice idea, but it is what we call as a hematoma and distraction arthroplasty after trapeziectomy, and supposed to give universal pain relief. However, we don't like the idea of a trapezium going down and collapsing over the scaphoid. So many surgeons, even in the USA, many surgeons have preferred trapeziectomy with ligament reconstruction tendon interposition as a treatment of choice for CMC joint arthritis. And that's what I do, and that's what I'll describe. So I do a ligament reconstruction and tendon interposition along with a trapeziectomy. Various technical variations have been described in literature for ligament reconstruction. What I do is I excise the diseased trapezium, I reconstruct the weak ligament, and I interpose a substance or a natural substance in the void left behind. I prefer to excise the trapezium in one piece. It has been described that you can excise it piecemeal also. That is how I do it. I take a volar incision, go up to the base of the thumb metacarpal. I use this cut end of a cancellous screw as a corkscrew. It helps to excise the trapezium in toto. You can, if you don't have it, or if you are the trapezium, the medial side of the trapezium we get a lot of problem in excising it. You can use a nibbler and remove it, and that's the trapezium which is excised. And then to reconstruct the weak ligament, classically the Burtons had described the flexor carpi radialis to APL suspension plasty, but I find that this is much better. The APL to FCR suspension plasty is much better, described by Thompson. And that's how we do it. This is the FCR tendon which is identified here, and these are the slips of the APL. You take half of the APL, and that is the half of the APL that has been incised at the proximal part, generally at the musculotendinous junction, and the distal insertion is intact. And then you wind it around the FCR tendon in the void. The APL is another advantage of this procedure is that the APL is a deforming force, and FCR is vital for wrist function. So I don't like to disturb it. So APL tendon, you wind it around the intact FCR tendon in the void and suture it there. It's a very simpler technique. And then for tissue interposition, I use the palmaris longus graft. I don't use any synthetic material. That's the palmaris longus that has been harvested with a stripper, and it has been rolled up as a anchovy, and with the proline suture I make a nice ball out of it, and then I put it in the void which is left by excising the trapezium. I give traction, manual traction on the thumb, as you can see. So we get more place, and then after the graft has been sutured, I take sutures on the capsule here so that the graft doesn't pop out from there. And then to stabilize the first metacarpal over the second, or to maintain the length, I put an intermetacarpal K wire like this. I find one K wire is enough. Initially, when I started doing this procedure, I used to use two K wires, but I gradually find that it's not required. With a K wire and a plaster support, that's single K wire and plaster support, that is quite adequate. Post-operatively, I give a plaster support for 4 weeks. I ask the patient to mobilize the IP joint of the thumb in that time. And then after 4 weeks, I remove the plaster and ask the patient to mobilize the wrist and the MP joint. At 6 weeks, I remove the wire and then ask the patient to do all the daily living activities in the home with the physiotherapy. Now, in this case, again, there is a doubt whether it's a grade 2 or grade 3, but patient was a writer, writing Marathi books. So he had a lot of pain, he could not write. So you can see that the thumb was subluxating and he wanted a treatment. He was not satisfied with the non-operative means. So I did this procedure, trapeziectomy with ligament reconstruction. And you can see this K wire holding the thumb very nicely with always when you in the post-operative phase, you see that the gap should be always seen more, because eventually this trapezium will collapse to a certain extent. And that's at 1 year, a nicely maintained joint. He's absolutely pain-free, and that's the function at 1 year. And that is what he has written in his introduction of the book, that I have helped him to write the new book. That's another case. You can see that now this case is also grade 3, but is presented with osteophytes here and degeneration here. And this was treated with a K wire and after excision of the trapezium. And this is 6 months post-op. And that's the function at 6 months post-op. Absolutely painless function. Now this is a bilateral CMC joint arthritis in a very senior orthopedic surgeon practicing in Bombay. I had treated him in 2009 for first one side, and then in 2012 for the other side. This is a 5 or 8 years follow-up, and he has no problem now. These X-rays were taken in, these pictures were taken in 2017, and he's still working, still operating, and this procedure really works very well. And this is 8 years now, it is 11 years post-op, and he's operating. His gap is very well maintained. He's absolutely painless. So what works in my hands for grade 3 or stage 3 CMC joint arthritis is a trapeziectomy. Is another thing with trapeziectomy. You have to couple it with a APL to FCR suspension plasty described by Thompson. I use a palmaris longus rolled up graft as an anchor for interposition. I always use an intermetacarpal K wire for fixation to maintain the gap. So trapeziectomy with LRTI gives pain relief, gives stability, gives mobility, and also strength, and we get a satisfied patient. I thank you all for your attention.